Welcome everybody. Reporting at least the occlusion rate, the time taken to return to work for the patients, the duration of the procedure, the pain evaluation, and the choice of the time points during the follow-up. Again, with a follow-up of at least 5 years. If we look at the great saphenous vein, we see that the data are more homogeneous. They're ranging between 1A and 1B, focusing on thermal tumescent. But it is also interesting to notice what the NICE from UK is recommending: to use endothermal ablation first if it is not possible to use ultrasound-guided foam sclerotherapy, if it is not possible to use surgery, and if it is not possible to use compression hosiery. That is indeed a way of also giving value to compression in case you cannot perform the other treatment. I think that it is important when we are evaluating the different techniques we are using to understand what we are looking at in terms of outcome measure. Because it's not just about the occlusion rate, it is also about the clinical success, it is about the patient reported outcome. This very interesting paper is showing us that in terms of anatomical success, for example, in this data collection, thermal tumescence was superior to ultrasound-guided foam sclerotherapy. But in terms of clinical success and patients' reported outcome, there was no significant difference between the two techniques. In terms of morbidity and complication, the same. And in terms of cost effectiveness, actually, foam was superior to thermal tumescent. Now, foam in terms of occlusion rate, as we have seen, is not as performing as the thermal tumescent techniques. But like for a good Italian pizza, it's always about the thickness. We should focus, as it is happening now, to the thickness of the venous wall to understand how we can eventually improve the occlusion rate. Because it has been demonstrated, indeed, that with the new techniques like mechanical-chemical ablation or the Flebograph catheter, it is possible to have satisfying results comparable also with the ones of thermal tumescence. Thermal tumescence remains also, according to the last, most recent published guidelines from the European College of Phlebology, the main indication, as you can see over here. At the same time, we should notice that GLU has recently published data, not just at 3 years, as in the European College of Phlebology guidelines, but also at 5 years, with the results that are totally competitive also with endovenous thermal ablation. So it will be interesting to see what will happen in the future, also in the recommendations for great saphenous vein. Whatever will happen, we should always focus on an important concept, in my opinion. We can have many different techniques that we can offer to our patient. But whatever brand new toy we are enjoying in our office, the strategy that we are using is always the same. Because indeed we can burn, we can vaporize, we can glue, we can torture this vein in many different ways, but at the end, the strategy is always the same. Ablation. The same ablation that was first described many years ago by Albucacis of Cordoba. It's like providing brand new weapons to the army, instructing the army to move always in the same direction. And this could be the explanation for which the recurrence rate remains always the same. And indeed, the guidelines in the last 10 years have recommended endovenous thermal ablation over traditional ablative surgery, but not because of a better recurrence rate, always because of their better invasiveness. At the same time, Cochrane reported that we can reduce the recurrence rate if we properly apply hemodynamic investigation, always eventually with the endovenous devices, but with the limited shrinkage, with a segmental shrinkage, for example, in specific point of the circulation, so to avoid ablating too much of this vessel. This kind of attitude has been demonstrated satisfying in terms of recurrence rate also in a very recent meta-analysis that is still showing the superiority in terms of recurrence rate of the hemodynamic procedures. So for sure, another hot topic for the present and future will be not just the technical improvement, but also the strategical improvement of our approaches. For sure, it is interesting to look at sclerotherapy. That is, in the end of the day, the thing we all do in our offices. It is interesting to note, for example, that if we compare European guidelines with the Australian guidelines in terms of maximum volume allowed, there is a significant difference with 10 cc in Europe and Australia presenting up to 20 cc of foam agreed in terms of treatment. The absolute contraindications are pretty similar all around the world, as you can see over